think that making a difference is why we all got into healthcare. And I think where we see the milestones throughout this past year in the work that we've done to both articulate how health equity is more than addressing health-related social needs, but also addressing institutional and structural barriers and addressing to healthcare delivery, as well as historical and institutional racism in healthcare and society in general, and looking at how we can improve and streamline our delivery processes to address those barriers. And I think in our project in particular, addressing a complex problem like readmissions reduction, as well as readmissions disparities, we've been able to connect those dots and bring teams together from clinical teams, operational teams, our community office, our Office of Diversity and Inclusion, nursing, clinical transformation, bringing all those teams together on a common cause to address that from a healthcare delivery as well as social drivers of health perspective. I'm really proud of that work.
Looking at our readmissions work is really focused on the social vulnerability index. That doesn't mean that those communities are uninsured or Medicaid patients. It just means this zip code, this area, it has the highest level of vulnerability when it comes to poor health outcomes. And so how can we look at our business strategy and say, this is where we need to be, this is what the clinic operations need to look like, partnering with that community to say what auxiliary resources need to be added to it. Food insecurity has been a major issue when socioeconomic status has even been controlled for. Other things that have come up, housing insecurity, of course, in Los Angeles it's a huge one, and it's like, it's not just affecting older adults, it's families, it's children. And so how can we ensure that we're extending care in a way that respects where and honor what people are dealing with in their day-to-day lives? And so these are the types of questions that have come up in our strategy sessions, in our planning, in our care delivery, and our care coordination. And I'm proud to say that we have been doing a really good job and also recognize that there's a long way to go.
Related to our top clinical goal around kidney health screening for diabetic patients, in January, prior to that, we had about a 2.5 percentage point gap when we look at our total screening for our total population versus our roll-up of persons of color, which is how we've been tracking it. And in January, it was the first time where that disparity was down to 0.5%. So essentially, we almost closed that disparity, which was our goal, and didn't see a gap within our population. So that certainly is also a proud moment to say, what we're doing is working, we're doing the right thing, we're getting our patients in, and not leaving a certain group behind because they just can't access what they need.
We made it a strategic goal to work on information to show what opportunities we have in our organization, our community around us. For me, when we started showing the information, like if there's a certain population where it looks like we're not giving them the best care and there's not health equity there, that I think when you first present it, people want to give the reasons rather than really look into why is this happening. And then also, once you start working on projects to fix opportunities, like for chronic conditions, for example, and you see opportunities there beyond sepsis, they seem to help many other projects that are going on too. So now I kind of feel like which thing worked. So that's what we're digging into. That's new.
So I think when we look at preparing the system for equity, that's where we've made a lot of progress. So that's understanding how demographic data is asked in the emergency care unit, or how to connect the social determinants of health from primary care units in the public sector to the patients we receive. That has been key. So when we think about the system and what the impact of this pilot program is in the system, is beginning to change those structures. So that means beginning to ask those questions, beginning to analyze quality and safety and experience data stratified. Especially on the experience data, we begin to stratify our NPS, we begin to stratify all of the different age caps and experience questions. So all of that is a structure for us to begin to do this work coherently in the future. So that has been a huge win in bringing in people with lived experience, compensating them for their work, to be thought partners in a lot of this, I think is huge, and something that has never ever been done at Einstein at the level of using methodology, aka improvement science, to improve inequities. And that's huge. All of the people who participated in the project have changed how they think about health and healthcare in their unit. And that, to me, is a huge success, because we are teaching healthcare workers that connecting to the humanity of our patients and our workers is at the center of patient safety, experience, lowering costs, etc. And if we don't do that, we can't do all the other things that we have goals to reduce or improve, etc.